The promise of JAK inhibitors in AD. Hello everyone, and thank you for tuning in. In this episode, we're joined by Dr. Neal Bhatia to discuss the emerging role of JAK inhibitors in atopic dermatitis. Dr. Bhatia, what changes would JAK inhibitors bring to the treatment of AD in the near future?
So the JAK inhibitors not only have the most promise, they have the most potential to change the way we approach not just treatment of itch and the immediate symptom relief, but also the change of the process of the disease state because of the way that the JAK inhibitors change or modify the process that makes the disease. In many respects for atopic dermatitis, there are many cascades of inflammatory cytokines that talk to each other, that work together. And this is both in adults and kids where the inherent defects such as filaggrin and many other of the interleukins that are working harder to create inflammation can be countered. We use the word actually diversity of cytokines in many ways to talk about how many different cytokines are working in atopic dermatitis, and the mechanisms of JAK inhibitors is very broad. It's not specifically working on several, like some of the biologic therapies that are more targeted tend to be focused on. So there's a very broad action, but yet still very safe in terms of not working on different cell lines or suppressing other immune responses. So I think the potential for long-term benefit with JAK inhibitors, as well as just the very rapid onset of itch relief that's been shown in the trials, both in adults and kids, shows a very strong potential for this class of drugs to reduce exposures to steroids, to reduce long-term flares, and really change the process for all of us.
What are some JAK inhibitors currently under clinical development for AD?
Many of them are involving different molecules that are also being studied for asthma, rheumatoid arthritis, and other rheumatological conditions. Tofacitinib was probably one of the first that was studied many years ago for rheumatologists and for their conditions. But now we have abrocitinib, baricitinib, upadacitinib, ruxolitinib, and several others that come by name that are both that are all in various stages of trials. There's also some topical versions of JAK inhibitors that are being tested. There's a newer one that is called a pan-JAK JTE052, as well as another one, oclacitinib, OCLACITINAB. All of these are being looked at in different sizes of study populations. And then, of course, there were some other topical ones that have not passed into different phases of trial. I think the point of the exercise is looking at the different mechanisms of these cytokines, as well as how they fit the process, specifically JAK1 and JAK3, and then the different STAT proteins that are involved also. So a lot of different combinations of things that really are going to determine which are the JAK inhibitors that would provide the best outcome.
Do you foresee that JAK inhibitors will play a role in both adult and pediatric AD?
Many of them are being studied for pediatrics at the same time as adults. The inherent defects are more obvious in pediatrics as well, and the risk, of not getting them off of steroids is a lot higher than in adults. So I think the utility for children is very high. I also think that if we are monitoring safety, including laboratory values and any potential outcomes that could affect safety in children, and we're keeping that on a high index of observation. I think the potential to incorporate this class of drugs to the pediatric population is going to be very useful for us.
Where do you think they will fit in with the other recently approved treatments for AD, or overall in the treatment regimen?
Well, I mean, right now we have, anywhere from topical and systemic steroids, topical tacrolimus, pimecrolimus, crisaborole ointment, and then the current biologics on the market, dupilumab, will be followed by tralokinumab and lebrikizumab. My real opinion of what I've seen in the trials as well as from the data is that the JAKis kinase inhibitors work very quickly, within days, creating reduction of itch as well as reducing the flare. I could see a paradigm shift where we actually use JAK inhibitors to put out the fire, and maybe after 2-3 months of therapy, or 12 weeks, as we've seen from the clinical endpoints, maybe we start biologic therapy as a maintenance, given that there's no lab monitoring and less issue of end organ potential issue, as we've seen with the JAKis kinase inhibitors as far as adverse events. And I think also we'll learn more about the long-term safety with these extension trials of the JAKis kinase inhibitors, where they may be the effective monotherapy. But I would like to see a paradigm where we start with JAK inhibitors, start biologics maybe in the second or third month, and then maintain these patients on biologics and use topical agents like crisaborole to treat the first sign of flare and put that flare out before it gets bad. Use topical steroids for when the flares are bad. And then, again, optimizing anti-itch care such as antihistamines, topical anesthetics, and those therapies.
What are the long-term implications for dermatology practice?
Well, the best advice I can give to dermatologists is to not be afraid of systemic therapies, to use the application of the mechanisms to counteract the process, and consider, the experience of the patient in terms of their quality of life if diseases are not adequately treated or treated without concern for mitigating the next flare. Reducing itch, getting patients to sleep, getting the parents of those patients to sleep and go back to work. These are all costs and intangibles that really have to be considered when only triamcinolone ointment and topical, anti-itch lotions are given to the patients, and we're not treating the entire disease state. So my concern is for dermatologists who, if they lose their edge and they're afraid of therapy, they may be missing out on treating the entire patient's issue that comes from the disease burden. And we may lose our access to these patients, to the allergists and other specialties where they don't have the same fears that dermatologists do about side effects and the unknown. I think dermatologists need to re-grasp the mechanism of actions of these therapies. They need to be aggressive in their treatment to, put out the fires and keep them away. And more importantly, we need to protect what's ours. We need to protect dermatology for dermatologists and remind patients why we have them see dermatologists in the first place. And this goes back to cleansing and moisturizing, and like I said before, incorporating topical and systemic treatments in combinations, and then optimizing these newer therapies so that they become our tools routinely, and so that we don't lose our scope of practice to other specialties.